you, Dr. Rajiv and Dr. Arun. Thank you.
Good evening, Dr. Daniel. I think we can start the case presentation. Yes.
Good evening, sir. Today I'm presenting a case of 52-year-old female, bank manager from Ernakulam, not an alcoholic or a smoker, came with the chief complaints of jaundice for 2 weeks, pruritus for 2 weeks, and upper abdomen pain for 1 week. Patient was apparently well 2 weeks back, noticed yellowish discoloration of eyes and high-colored urine, which was not associated with fever or gray-colored stools. Patient also complaints of generalized itching all over the body with no diurnal variation, not associated with redness or scaling of skin. Patient complains of dull aching upper abdomen pain, which was continuous in nature, no aggravating or relieving factor, not radiating to back or shoulders, not associated with nausea or vomiting. Patient also complains of an unintentional weight loss of around 4 kilograms in last 1 month. Patient has no history of change in bowel habit, no history of hematosis or melena, no history of abdominal distension or bloating or dyspepsia, no history of night sweats or evening rise of temperature, no change in sleep pattern, no history of fatigue or anorexia, tendencies, no history of jaundice in the past, no history of lumbar swelling anywhere in the body. So no history of dysphagia or odynophagia, no history of cough or breathlessness, headache or seizures. Presenting past medical history. Patient was diabetic for 2 years on OHA, hypertensive for 5 years on medication, dyslipidemic on statins for 5 years, not a known case of HIV, hepatitis B, hepatitis C, no history of major illness or major surgeries, no history of drug allergies, no history of previous blood transfusions. Personal history, married for 25 years, 2 children alive and well, mixed diet, not an alcoholic or smoker. Family history, no family history of malignancy. Sir, I finished the history of personal illness and family history, all the histories. Yeah.
Okay. Okay, good evening all. Thank you, Daniel, for the initial presentation. Could you just summarize the case that you have presented? And before that, I think for the audience, Dr. Rajiv also requires no introduction. He was my mentor too at Adair Cancer Institute and mentor to many of my seniors too. So I think we are fortunate to have Dr. Rajiv as one of the examiners here, and thank you sir for joining us here. Probably, Daniel, you can go and summarize the case in say 3 or 4 lines.
So, 52-year-old female presented with a history of jaundice, pruritus for 2 weeks, and 1 week history of upper abdominal pain, and with the unintentional weight loss of 4 kilograms in one month.
Okay, it's a gradually progressive jaundice of 2 months duration and with significant weight loss.
Wait. 2 weeks duration and weight loss of 1 month.
2 weeks.
So 4
okay.
weeks. 2 weeks history of jaundice and pruritus, and 1 week history of upper abdominal pain.
Okay.
And
but you said there is no loss of appetite.
No loss of appetite.
So no vomiting also.
No vomiting.
Okay, so from the history, what would you attribute her complaints to? We will only discuss malignancies. I think we'll not discuss non-malignant causes. We'll only go through malignancies.
My probable diagnosis are like
no, summarizing.
So 52-year-old female, not an alcoholic or smoker, presented with a history of jaundice and pruritus for 2 weeks, and 1 week history of upper abdominal pain with unintentional weight loss of 4 kilograms. My probable diagnosis are like head of pancreas tumor, carcinoma, or biliary tree malignancy, or primary hepatic malignancy, or It can be lymphoma with the nodes.
Okay, lymphoma leading to compressive obstructive jaundice.
Jaundice, or and maybe down the line, maybe metastatic disease with the liver, GI malignancy with the liver mets.
So, Dr. Daniel, I think that's a broad differential diagnosis. So, how would you sort of rule out a hepatocellular origin? You said probable HCC, primary HCC, or a metastatic liver disease that is primary from elsewhere. What do you think is odd in this patient? Would you consider that as one of the possibilities? If no, why? Yeah.
Sir, patient is not an alcoholic or a known case of any chronic liver disease.
Okay.
So probability of
Okay.
HCC goes down, and the short history of symptomatology may not be a metastatic cancer.
I think more important, I think you
Okay.
told more like an obstructive jaundice, right? So obstructive hyperbilirubinemia will be unlikely in a primary HCC. And usually pruritus and other things may not be a common finding. And you said lymphomas as a broad etiology. So 2 weeks history there she's giving. So that's a very short, and if at all it's an aggressive lymphoma. So would you like to qualify it further, or is Hodgkin's lymphoma as possibility, or what are the lymphomas which you think is possible?
Non-Hodgkin's.
Okay. Non-Hodgkin's. Can you just again sort of harness a guess which would be the lymphomas which secrete?
Fast DLBCL.
Okay, DLBCL because of the commonality. Epidemiology wise, DLBCL should be the common and can have unusual presentation. Any other lymphomas that can seek the pancreas, especially in younger adults who presents with jaundice? Sometimes they may even undergo a Whipple's and finally it turns out to be a lymphoma. Aggressive lymphomas in Burkitt's, very good. So Burkitt's also is possible because it's showing a very aggressive history, right? One critical comment on your history taking, though otherwise it was exhaustive, is you mentioned the patient does not give history of hepatitis B or C. These are usually silent diseases. So most of the time patient may not know about it. So unless it's a well-qualified healthcare professional who is your patient, very difficult to take that history in a practical sense, because many of us even may not know whether we are hepatitis B or C positive. So I think that may be omitted, though it may add to your differential. You have nicely told there is no history of previous episodes of jaundice. I think that should take care of many of those CLDs. But a known history of hepatitis B and C will be a bit far-fetched, because many times it will be at the diagnosis of malignancy they might be detected. Or, it would have been more accurate if you had told she is vaccinated for hepatitis B or unvaccinated. That's more of a, good indirect way of checking on the hepatitis B status. Just a comment on that. And I don't know anything else on the history you want to.
Yes. Why did you ask for history or family history? I mean, stress on the family history. Is there anything that we would, supposing it is yeah.
BRCA, breast malignancies.
Breast malignancy in this patient. Why?
For pancreas primary, or
so you are indirectly asking for history of a BRCA-ness. BRCA.
So there was no history of any malignancies in this. Maybe important. Maybe BRCA, there's BRCA associated malignancies in the family.
Okay.
So again, Again, just a bit of a critical comment because the slide is open in front of me. Usually when you present it for me. So it says no family history of malignancy. You will know that there is no family which will have no malignancy in the family. So each of our family members will have malignancy. So I think it would be nice if you can qualify, as Arun told, there is no young cancers in the family, or there's no breast, and you can even tell there is no BRCA related cancers in the family. That sort of will qualify, and we will know that you have taken that extra effort to find out whether it's a hereditary pancreatic cancer. So I think you can qualify it a bit better in the family history part. Please go ahead. You can go ahead with the explanation.
General examination and vitals, conscious and oriented, ECOG 1, height BSA of 1.67, BMI 27, vitals normal, icterus present, no pallor cyanosis, clubbing or pedal edema, no generalized lymphadenopathy, no spironevia or palmar edema or sandalisma or signs of CLD. Abdominal examination, abdomen distended, umbilicus inverted and slit vertical, no previous surgical scar, no dilated vein or peristalsis, no visible mass or swelling. Palpation, abdomen soft, non-tender, no tenderness, guarding or rigidity. Liver palpable 4 cm below the costal margin. Liver is smooth with no nodularity, no non-tender, no splenomegaly, no other mass palpable. Percussion, no shifting dullness or fluid thrill. Hepatic span of 18 cm. Auscultation, bowel sounds normal. Normal. So finished my examination part.
Again, if you can summarize, just the positive findings and the relevant negative history.
Patient has icterus present and liver palpable 4 cm below the costal margin and liver span of 18 cm. No abdominal, no ascites, and
okay, so in summary, it's a 52-year-old lady with symptom suggestive of obstructive jaundice, and on examination, only icterus is there and a palpable liver, significant liver, hepatomegaly. Correct?
yes, yes, sir.
So, what would be your differentials now?
It can be primary liver malignancy or cholangiocarcinoma or
primary liver malignancy as in hepatocellular carcinoma.
Hepatocellular carcinoma.
That would be your first differential diagnosis now.
Or cholangiocarcinoma, intrahepatic cholangiocarcinoma.
So
then
why
head of pancreas with the liver mets.
Okay, so in our history, we had almost ruled out hepatocellular carcinoma as ruled out in the sense would be going down more down in the line, correct?
Yes, sir. Yes, sir.
Jaundice, features of obstructive jaundice is rare. So why would it come in the first as a first differential now?
Cholangiobiliary pre-malignancy. Biliary malignancy.
Okay, one of the biliary malignancies. Okay. Then?
Head of pancreas with liver mets.
I think rather than saying head of pancreas, you can say probably pancreatic malignancy. So to explain the hepatomegaly, you're thinking of liver metastasis. Yeah, epidemiologically, I think hepatocellular carcinoma should still come way down in the list compared to the other two. So anything else with the hepatomegaly?
Non-tender, liver is smooth, non-nodularity, non-tender, 4 centimeter down the constal margin.
Okay. Tough exam case also, sir. Sir, Rajiv sir.
Yes. So a few again comments. I think you mentioned about spider navex and talisma. I hope you know it, because I am not very sure how to go about looking at it. And again, I've not seen the patient, but is she a fair lady, or the pigmentation? Because some of these findings may be very difficult to find. More practical would have been, she said the intense pruritus was there. So was there any pruritic marks? All those would have made more sense in the examination, because I think you in the history itself told there is no major history suggestive of CLD for a young lady. The other thing is, as Arun rightly told, just because you have a liver palpable, you don't change the overall clinical picture. It's basically an obstructive jaundice with hepatomegaly. So need not bring in hepatocellular carcinoma again. As you rightly told in the history, there is no alcoholism, there's no CLD features for us to bring HCC as the first differential. So I think as a whole, you should sort of correlate both the history and findings and then try to bring in. And your other differentials were a lymphoma and rarely metastasis. So it would have been nice if you had told a negative clinical findings, like there's no supraclavicular node or no splenomegaly or a generalized lymphadenopathy to, so that we know that you've gone in a systematic way to rule out your other differentials at the end of the history. So that way, if you present, the examiners will find it that you are going in a logical way. So just a comment. So how do you want to proceed from now onwards?
Yeah, I will want to conduct investigations, diagnostic as well as ancillary. For diagnostic, I will go ahead with the CT abdomen, contrast and CT abdomen. For ancillary testing, I'll go for CBC, LFT, and tumor markers, CA 19.9, CEA, and AFP.
Again, I mean, practically we won't be classifying which is diagnostic, which is ancillary, but it makes sense. But then that will lead to an argument and explanation. How is a CT going to be diagnostic in this case? How does CT helps you make a diagnosis? Can you make a diagnosis with a CT scan in this case?
No, sir. With CT, we have to go for biopsy, plan for biopsy, primary.
Yeah. So I think in this particular, I don't think you can call a CT scan as a diagnostic. You are right. Most of us will do. And again, I think the usual question would be, why not an ultrasound initially? Because if the liver is studded with metastasis, because again, hepatocellular was your first differential. So if you have very advanced disease, are you going to really go ahead and do a CT? Or if you're doing a CT, then whether you will end up doing a PET CT later. So I think, again, there you should rely on what your institute is doing. And if you're at your place of training, if ultrasound is asked, I don't think there is any thing wrong in doing an ultrasound, which is a very good investigation to start off with. But I'm sure many examiners may ask why ultrasound initially. So you need to prepare for both. So if you straight away ask for a CT, usually many of us will end up doing PET CT if you require as a staging. So you'll be doing a CT twice. If you do an ultrasound, finally we'll end up doing a CT also. So try to get your argument right for both the scenarios if the examiners ask. Anything specific, as Arun was trying to guide you, it was more like a hepatobiliary primary. So any particular CT study you would like to ask a junior radiologist who is on duty? Is there any particular specific contrast CT that you would like to do in this patient?
CT with pancreatic protocol.
What does pancreatic protocol mean? What is a triphasic CT scan?
Triphasic means there will be arterial phase, venous phase, and equilibrium phase.
So how do they do it generally?
First 15 second, 20 second is arterial phase, 20 to 40 second is venous phase, and after 10 minutes is delayed phase or equilibrium phase.
Okay, so how does triphasic CT help us compared to a conventional CT in hepatobiliary malignancies?
Liver has a portal supply, and tumor in liver has a arterial supply. HCC will have an arterial supply, so it will brighten up with the contrast of liver, which has portal supply, which happens later in the venous phase. So there will be a contrast will help you to hyper enhancement in HCC, and later on in delayed phase also this will HCC will arterial supply. HCC will remain as a hypodense compared to portal venous supply have a contrast uptake.
If you are at a center where a high resolution MRI is commonly done, and you have it, it can be easily done. Would you like to ask for a MRI straight away, or what are the advantages of an MRI over CT in this situation?
MRI will have vascular structures and soft tissue will be better delineated with the MRI.
Pertaining to this patient, how do you think it will help?
The portal vein, portal system, then cystic duct, biliary ducts, everything will be more visible with the MRI sequence. Then
you may be able to identify the area of obstruction. That's what you are trying to do. Okay. Right. Any other particular? You said regular LFT. Any other blood investigations that you would ask?
AFP, KCA 19.9 and CEA for tumor markers.
Sure. I don't want to ask.
Yeah. So you have the values for this patient?
Sir?
The lab results?
Lab results, sir.
And regarding that, the triple phase CT that you were talking, is it useful in pancreatic malignancies also? So we usually use it for hepatocellular carcinoma. The hyperenhancement and delayed washout is diagnostic for hepatocellular carcinoma. We don't need a biopsy. So it's one of those malignancies where you don't need a biopsy, right? Hepatocellular carcinoma. It's an imaging diagnosis. And what about pancreatic malignancies? How would be a phase CT or a triple phase CT be useful in pancreatic malignancies?
I don't know, sir.
Yeah. Okay. Yeah, it's that smaller pancreatic adenocarcinomas may have this phase attenuation changes. So smaller lesions may be better picked up on phased CTs. So that is one advantage with phased CTs in pancreatic cancers also. Okay. So
just to add on to what Arun said. So in this patient, you have an option of doing a PET CT straight away or a high resolution CT that Dr. Arun was discussing. Which one would you do?
So I will go for triple phase CT rather than PET CT.
Why?
Sir, the triple phase CT may not be with the PET. We can't, maybe not possible. So first we'll go for a primary. It will be triple phase CT. I can go with the ultrasound, and then if something.
You're going back to ultrasound.
Like most of the time, the CTs which are tagged with the PET won't be as high resolution as what we would want for a hepatobiliary malignancy. So you're right. A good contrast CT should be better.
Blood investigation, CBC, HB 10, TLC 10,000, platelet 250,000, creatinine 0.9, total bilirubin 6.8, direct bilirubin 5.7, SGOT 84, SGPT 182, ALP 464, albumin 4.8, CA 1.67, CA 19.9, 31.6, AFP 40, pre-observology negative.
Okay, so what does this tell you? I think we'll go. Yeah.
Yes, sir. Sir, LFT, there is a obstructive picture.
Okay. Obstructive
with
jaundice.
Tumor markers normal. AFP, CA
Okay.
19.9, CA normal. And sir,
Yeah.
then, sir, we have done MRI. So, this is the patient.
Albumin 4.8.
Albumin 4.8, sir. Higher.
Okay.
Sir.
What does it suggest? The patient probably may not be
Metastatic.
Metastatic, right?
Not metastatic. Albumin is normal.
No, albumin 4.8 and platelet 2.5 lakhs. What would it tell you about the patient's, say, systemic function?
No CLD.
No, it's unlikely to be. Okay.
No CLD.
Right. Right. Carry on.
MRI and MRCP was done, which was showing heterodense lesion measuring 10.2 into 9.5 centimeter, seen involving segment 5, 8, 4A, 4B associated with capsular retraction. Mass is peripherally enhancing in arterial phase and centripetal filling in venous phase, no washout. Mass is in close relation to right hepatic vein, which is patent, features of cholangiocarcinoma. So this is the CT. It's MRI. So investigated biopsy was done, which was showing well-differentiated adenocarcinoma. IC favors cholangiocarcinoma. And PET-CT was done, no lymph nodal or distant metastatic lesion. And was planned for laparoscopic hepatectomy.
So what do you think the IHC would have been?
Sir, CK 7 positive and CK 19 positive. Sir.
That is enough to make a diagnosis of cholangiocarcinoma.
Then,
so how do you systematically go about? What were your differential and how do you try to differentiate based on your IHC markers?
The differentials were HCC, cholangiocarcinoma, pancreatic carcinoma,
and metastasis.
Lymphoma.
Yeah. And probably a metastasis from GA primary.
GA primary.
So how do you go about differentiating based on IHC?
Sir, I will go for LCA for like lymphoma. Then
LCA most probably not required because the pathologist would have given you well-differentiated carcinoma. Then you don't need to waste your resources on LCA. When will you do LCA if the report was?
Poorly differentiated.
Poorly differentiated carcinoma?
Carcinoma, then no need for lymphoma. LCA. Sir.
So if it is usually
neoplasm.
So pathologists are not able to characterize, then only we need to do from the primitive markers level. If they've already LCA not usually required. So what are the basic IHC panel you would ask?
CK7 and 20. CK7 and 20. CK7, CK20 positive will be colonic malignancy. And CK7 negative, CK7 negative, CK20 positive, colonic malignancy. Then CK7, CK20 both negative, maybe HCC, RCC, or prostatic cancer. Then CK7 positive and CK20 negative, breast lung, ovary, and all, and or cholangiocarcinoma, or CKS7 positive, 20 positive urothelial, as well as cholangiocarcinoma.
Just can you come back to the next slide, please?
Okay.
No, I think no, next one. So yeah, so PET CT was done. Yeah? There's no distant metastasis. So can you differentiate the type of cholangiocarcinoma based on the clinico-radiological features?
It was a intrahepatic cholangiocarcinoma involving segment 4, 5, and 6, and
so in this patient, they were planning a right hepatectomy, right?
Right hepatectomy was planned, but actually this planned on opening laparoscopy, it was found it has gone to peritoneum, and plan was abandoned.
That was distant. So let us keep it as if it was a locally advanced disease, and if again the disease was confined to the liver, and otherwise the same lady, and she has some involvement of the left lobe also. What would be your plan?
Plan for we'll discuss in tumor for resectability. If not resectable,
bilobar disease will be usually resectable upfront?
Not resectable.
What will be the options for a young lady who doesn't have any other comorbidities here?
So, the plan for palliative chemo.
Palliative, palliative, okay. Even if that is a localized disease.
Yeah.
Any other options would you consider?
Like HCC for like TACE and for
TACE for
cholangiocarcinoma will give chemo.
So you give a perioperative chemo.
Perioperative. Neoadjuvant is not operable. We'll go for palliative chemo if we'll see for response, and maybe radiation to downsize it. Operability can be. So I don't cholangio. I don't know, sir, whether we. I don't know how much we can go for like neoadjuvant chemo and then chemo radiation, and then.
Is liver transplantation an option?
Yes, sir. Transplantation, cholangio is not an option. HCC we can. So cholangio is no data for transplants.
You feel it's not a good disease to transplant. Okay. Right. So in this patient, she had a metastatic disease. That's what you told peritoneal at time of diagnostic laparoscopy.
Yes, sir.
Peritoneal disease was
peritoneal disease.
So how would you go about treating her?
Sir, gemcis, like 6 to 8 cycle gemcitabine cisplatin, and newer studies have come with immunotherapy also with durvalumab, which has shown overall survival benefit. If affordable.
Is durvalumab the only immunotherapy we can use?
Topaz study was shown actually control trial, randomized control trial, phase 3 trial, which has shown.
Durvalumab is FDA approved, and you use it usually with the gemcitabine and
cisplatin.
Any other immunotherapy recently got approved?
Pembrolizumab.
Yeah. And if let us say due to logistics, we cannot offer immunotherapy, and we need a good response to bring her into symptom control. Is there any other option?
GEMS is with the nab-paclitaxel.
So triplet chemotherapy also is one of the options. Okay. Molecularly, if you do a comprehensive NGS testing, do you think it makes a difference for her?
MSI high or BRAF mutation, IDH mutation, IDH1, and then HER2 MSI.
Sure. So some of these
shown positivity.
Yeah. And how will you be able to prognosticate based on your NGS testing? Is there molecularly different entities of cholangiocarcinoma?
No, sir. I don't know.
I don't know.
Yeah. So yeah, I think systemic therapy. I think he's mentioned all the probably the protocol that what would be the protocol that you would follow in this case? She's got peritoneal mets, so definitely the intent of treatment would be. What would be the intent of treatment here in this patient? Okay, so resectability probably may not apply because she's got peritoneal mets already. So the intent of treatment is palliative, and I think maybe the systemic options you have discussed regarding all the targets also. Anything else? Yeah. So what are the tumor agnostic, tissue agnostic approvals for immunotherapies or targeted therapies now that you're aware of? Did you get the question?
Yes, sir. Tissue agnostic.
We have tumor agnostic approvals for any agents, targeted therapy or immunotherapeutic agents, and probably in this case also that would be relevant. What would be that?
Mainly in second line, if you are using
second line chemotherapy or immunotherapy.
No.
Okay.
He asked for tissue agnostic approvals. Usually they'll be targeted therapy. So is there any MSI? I think
MSI we can go for.
Yeah.
Immunotherapy. Okay.
Is there any other mutations that you are aware of? FGFR2 inhibitors?
FR2 inhibitor, like maybe get banned.
Okay, he's read about it. NTRK?
NTRK 0.1%. You can larotrectinib and entrectinib.
That's also tissue agnostic, correct? Yeah. Okay. So what did we do for her?
Sir, we go ahead with the GEMSIS with the 4-cycle. Then it was a partial response. Added durvalumab. Sir, 6-cycle she just completed, and given answer sister completed.
Okay. So suppose this case, let's forget the imaging finding. Suppose this case was just a pancreatic mass, and CA19 was the same, 31.3, and the surgeon feels that it is an operable pancreatic cancer. Would you need a biopsy in that case?
Sir, no, sir. We can go ahead with the surgery. If it is operable, we can go ahead with surgery.
If it is operable?
We can go ahead with surgery without biopsy.
Okay. So it is not mandatory to have a biopsy in a suspected pancreatic cancer if it is directly operable. When would you need a biopsy? Suppose it is pancreatic cancer.
So when we go for a chemotherapy or neoadjuvant, we have to confirm with the biopsy before starting chemotherapy.
Correct, you're right. So what are those malignancies where you do not need a tissue diagnosis?
HCC has a image product imaging we can find with the triple phase CT in a cirrhotic. we can go ahead with the triple phase CT. We can make a diagnosis.
Okay.
Pancreas, gallbladder. If surgery is the plan, we can go ahead with surgery without biopsy.
Okay. Pancreas. Okay. Then
Then,
I think you would need 10 malignancies without tissue diagnosis where you can treat it.
choriocarcinoma, we can treat with the beta HCG and
Choriocarcinoma. Okay.
choriocarcinoma.
Then more common ones.
Sir,
Germ cell tumors.
yeah.
Do we need a tissue diagnosis?
No, sir, we can with the ultrasound finding and
So that would be the commonest scenario where you would proceed without tissue. Then pediatric malignancies.
pediatric malignancies.
Like what? No tissue diagnosis.
Medulloblastoma.
Medulloblastoma. Okay, when you're directly going for surgery. Okay. More common pediatric
Sir, nephroblastoma. Nephroblastoma.
Nephroblastoma, even probably more classical. Nephroblastoma is correct. You can go for
Williams tumor. Williams tumor.
No, that is a
Nephroblastoma. The same. Then.
Come on. What about retinoblastoma?
Sir, retinoblastoma. Okay.
So these are the ones you go for. Okay, fine.
This patient, if you are able to do a right hepatectomy and it was completely resectable, how would you go about treating him after the surgeon sends back to you?
Sir, adjuvant, there is no role for any.
No role.
No. What is Bill Cap study?
Bill Cap studies showing capecitabine single agent has shown survival benefit. Overall survival of with capecitabine 8 cycle, 51 months of median overall survival. Compared with placebo, it is 36.
Okay.
So there is a role for adjuvant therapy.
There's a role for adjuvant therapy.
Yes. Okay. Okay.
I think that should be it, Arun.
I think so, sir. I also don't have any more questions.
Yeah. And Boban, if you want something to add, you can add.
No, thank you. That's it. No, always abdomen is right from our MBBS day. We are told that the abdomen, eating an abdomen case is always the difficult thing because the differentials can go from any very varied differentials can be there, especially when you're dealing with malignancies. Also, it can be starting from hematological malignancies to solid. It can be all kinds of discussions can happen. So most of the things were discussed. I hope that the postgraduates actually benefited out of this discussion. So next month we will be coming up with a different case presentation, and I'd like to thank Dr. Rajiv and Dr. Arun Philip for this initiative for taking up the responsibility of the examiners. Thank you, Dr. Rajiv.
Thank you.
Thank you, sir. Thank you, sir.
All the
Thank you,
best.
sir.
Thank you.
Yeah, Daniel, well done. I think you have done well. So, yeah.
Thank
Okay.
you.
Yes.
Yeah.
Good night.
Good night. Good night.